At Professional Risk Management Services, our medical liability insurance program for psychiatrists and behavioral health group practices, the Psychiatrist Program, is designed to meet your needs throughout the various stages of your career. As a national psychiatry-specific program, a policy with PRMS can cover child and adolescent, forensic, early career, and military psychiatrists, as well as moonlighting residents and fellows, part-time practitioners, and telepsychiatrists. Learn more about how PRMS can protect you.
Well, hello everyone. Thank you all so much for joining us here today. My name is Alicia Ali Khan. I'm a PGY3 resident at Georgetown. Really excited to have you all. I'll first tell a little bit about myself. Some of my interests include perinatal and women's mental health. I'm really interested in advocating for women's rights. And some hobbies include skiing, snowboarding, hiking, puzzles, making craft cocktails. And I'm really excited to have you all today for our third official Washington Psychiatric Society podcast. And I'm really excited to introduce our guest of honor and speaker today, Dr. Constance Dunlap, who's a great personal mentor of mine and somebody who I'm really inspired by. I'll talk a little bit about Dr. Dunlap and her background. So she's a psychoanalyst and board-certified psychiatrist. She has a private practice in DC. After earning her MD at Georgetown University, she completed her psychiatry resident at George Washington University and graduated from the Washington Psychoanalytic Institute. She currently serves as a clinical professor at GW, where she teaches medical students and psychiatry residents. She's also a leading advocate for racial justice and mental health care. Her contributions in the field include articles in Psychiatric News, Capital Psychiatry Magazine, Clinical Psychiatric News, the Journal of the American Psychoanalytic Association, and the Journal of Psychoanalysis, Self, and Context. She's also received several awards, including the Washington Psychiatric Society Psychiatrist of the Year, the American Society of Psychoanalytic Physicians Distinguished Citizen Award, and the APA Assembly's Area 3 Resident Fellow Mentor Award. She's also a Distinguished Life Fellow of the APA, a Fellow of the American College of Psychiatrists, and a member of the Black Psychoanalytic Analysts Speak. And she currently serves as the APA Assembly representative to the Area 3 Council. Welcome, Dr. Dunlap. We're so excited to have you.
Thank you, Dr. Khan. I'm looking forward to this conversation with you.
So just want to give a little bit of context about, what this podcast is about. So this was started by Dr. Swarty, our current president, and also co-sponsored by the Career Learning and Mentorship Committee, the CLM committee, and we're hoping to use this podcast to facilitate connection and enhance knowledge and understanding between the mentors and the mentees of the Washington Psychiatric Society. So I think I'm really excited to chat a little bit more about all of your great accomplishments, Dr. Dunlap, and get to know you, but also kind of explore your journey and how you got to where you are. I know there might be medical students and residents in the audience, so I thought it might be interesting to kind of start out with where you began. I know that you completed an internship in OBGYN and then transferred to psychiatry. Can you tell us a little bit about your journey to becoming a physician, specifically what motivated you to pursue psychiatry and psychoanalytic training?
That's a good place to start. So when I was in medical school, I started medical school not knowing what discipline I wanted to pursue. And one good thing about Georgetown is that it exposed students to psychiatry each year. First year you have patient interviewing, and then there's another rotation. And so I kept that in mind, but I had an interest in OBGYN. And so then I had a crisis several weeks before match. I was doing a rotation with Luke Grandy, and we were at a home for young women who were pregnant, basically pregnant teens. And I remember just being with him, and all of a sudden it clicked that this is what I wanted to do. Dr. Grandy, some may know, is an analyst. But prior to that, I had done a rotation during third year on the psych unit at the VA and was encouraged to pursue psychiatry. But at the time, that was not my interest. So a few weeks before match, I realized what I wanted to do, and I went into the dean's office with the plan to announce that I was going to pursue an MPH, a Master's of Public Health, with a focus on maternal health. And the dean was Father O'Brien. Some people on the call may know Father O'Brien. Dean O'Brien was a priest, a psychiatrist, and a dean, basically a one-stop person. so, so Father O'Brien talked me off the ledge, and he let me know I had matched. At this point, I had matched at the hospital center, and Father O'Brien let me know that I needed to do an internship. So he encouraged me to go ahead and do the internship. And he said, "You need to do this, become licensed." At that time, I had no idea how to become licensed. So fast forward, did the internship, and in the middle of the year, decided, and this took courage, I decided that I did not want to pursue OBGYN. And people asked me, they were puzzled about how I could leave OBGYN and go to psychiatry. And by the way, in my class of 205 at Georgetown, maybe 5 people went into psychiatry. The idea is that you would not waste a good medical training on something like that. And so in the middle of the year, a position came available at GW, and I went and interviewed with Cy Perlin, the residency director at the time. And I remember at one point, because I was also thinking about pursuing USC, and at one point in the interview, Dr. Perlin said, "Well, you don't want to go out there. It's a very smoggy city." But we had connected, and I finished the internship and came over to GW, and has been one of the best decisions for me.
Wow, thank you so much for sharing that powerful story. And, I think a piece that resonates with me is actually, I went to medical school also to Georgetown, and I was interested in ophthalmology. And then I got to my third year rotations and decided, wow, psychiatry is really amazing. And I think this is what's for me. And that can be really scary, to change those career paths and to make that decision. But ultimately, sometimes having an atypical path can give you kind of perspectives that you might have never had. Do you feel like kind of taking that path has given you any perspective or informed your psychoanalytic practice?
Well, absolutely. And you just mentioned something that's very important. And so since I had done the internship and finished training, when I finished training, I had an office in the Columbia Hospital for Women's professional office building. And one of the reasons I went there was because I had this internship, this training in OB. And so I became the go-to psychiatrist. I was familiar with antepartum care, postpartum obstetrical care. I was familiar with GYN. And so I was called to do a number of consultations. It would be probably what we consider CL at this point. And so I felt very comfortable going to the hospital to address whatever came up. I really like being a physician. And so I was able to use everything at that point.
Thank you so much for sharing that. And speaking of training and unique experiences in training, I understand that you were actually one of the only Black trainees in your residency and during psychoanalysis training. And I know that you've also done quite a bit of work with racial justice and relating to the discussion of race or even lack thereof in training and in psychoanalysis. Can you talk a little bit about how this and your experience might have shaped your practice?
I don't know if I was the first Black person to finish residency at GW. I was either the first or second. In psychoanalytic training, there had been Charles Prudhomme before, which we only discovered recently, Ed Kirby, and then Carlotta Miles, and then I finished training in 2001. And this is a question that would come up, what is it like to be the only Black trainee? Well, I had become used to being the only Black person for some time. And so this is just how it is. But I think what people may also not know is that I am from South Carolina, and I started elementary school in a segregated Black school. And I spent the first 3 years in a segregated Black school. And this is clearly after the Brown decision and after schools were desegregated, I was among students who integrated the formerly all-white public school. And so, stayed there for a few years. My family relocated to New York, and then we settled in DC. So my family has also been part of what is considered the Great Migration something that I didn't discover until I remember seeing a painting by Jacob Lawrence in the Phillips. He's a Black Renaissance artist, and it's also captures that experience is captured in Isabel Wilkerson's book, The Warmth of Other Suns, and the warmth of others, yeah, warmth of other suns. And I mention it because when people think of immigrants and migrants, they think of other people. They don't think about Black people migrating within the country. So I've had that experience and can relate in some ways to the immigration experience. But clearly I didn't start medical school planning to go into psychiatry, and I didn't start with the intention of focusing on race. There was something that caught my attention in 1993. There was an article in the newspaper. There was an article about AT&T was trying to convey how telecommunications have become globalized. And so the illustrator decided to do a map, and it was a map of, the US, North America, Europe, and Africa. And there were people represented everywhere except in Africa. They actually used monkeys. And of course, this was discovered. AT&T addressed it. The illustrator apologized. But I was intrigued by that. In fact, I still have that article. I've been doing some decluttering, and I pulled it out. And at that time, we didn't really talk about race as much. But clearly, someone who has lived, as a racialized person, that caught my attention. And what I realized was this was done unconsciously. And that's one of the reasons that I have also really appreciated psychoanalytic theory and technique, because it can get to that.
Yeah, wow. I can't imagine how it must have felt to see an image like that. What did you feel inside when you saw those things, and how did that impact you?
Well, it's comparable to what we experience today. I mean, it's a denigrating image. It's evidence that people have prejudice.
Mm-hmm.
Some people have racism, but all of us have prejudice. What's important is to acknowledge that and to try to get an understanding of what that's about in order to deal with it.
Mm-hmm.
I could say a little bit more about that when we talk about advocacy, but it's those kinds of experiences that motivate me to be involved in education, be involved in advocacy, and be involved in helping people to see their blind spots.
Mm-hmm. And that's great. And I'm glad that that's what you've taken away from that experience, because I can imagine others might see those images and really have doubts about themselves, or even imposter syndrome, those kinds of things. So I'm excited to talk a little bit more about your advocacy efforts and hear all of the great work that you did. I think a piece of it, which I've also kind of made fun of you a little bit about, is that you're so humble and you never talk about all of the great and big things you did. Like, all this time I've worked with you, I had no idea that you were a past president of WPS. So I'm just wondering, can you tell us a little bit more about how did you get involved with WPS? You've been an active member of the board for several years. Can you tell us a little bit about your role and what you've gotten out of WPS?
That's a good question, too. When I finished, so I graduated from analytic training in 2001. And for a little time, I was on the Washington Center for Psychoanalysis board. And in fact, I think I started when I was a trainee, a candidate. And then at one point, I was on that board, and I was invited to join the board of WPS. So there was a year where I was on both boards. Of course, that's madness. But at one point, I was on both boards, and it did give me an opportunity to think about where I wanted to be. And I think that having been in analytic training and in the community since 1994, it was time to get out of that. Can be a regressive environment, even though it's a wonderful experience. I really love being in analysis and love being in training. But at that point, I decided to become more involved in WPS. And I have this image of, these are the people that come to my mind: Elliot Sorrell, Catherine May. I mean, these people have been, part of the vanguard of WPS, and they reached out to me and asked me to participate. So I'll just take you through this quickly. So I started as the chair. Well, first I joined the board, I think as an at-large member. And then I became the chair of the DC chapter. We have Maryland, DC, and Virginia. So I was the chair of the chapter for a couple of years and then took a break. And then I came back to WPS and I became the president of WPS, I think around 2015 or so. Anyways, the president-elect, president, immediate past president. But I was the president of the board. And then this also illustrates the importance of sponsorship and mentoring. As I was finishing my term on the board as immediate past president, Roger Peel had been elected as the Area 3 board trustee, which is a 3-year term. So he had finished 1 year, and he and Elliot actually took me out to dinner, and they asked me to fulfill Roger's 2-year term, and which I did. That's how I became a rep, a WPS Assembly rep. And then after that, and this happened after George Floyd, after that window opened, there was a real focus on looking at the organization and trying to improve the representation. And Bill Greenberg was the area representative, Area 3 representative. Mel Melvin was the deputy representative. And Mel decided to not run for a second-year term, and which opened up the possibility of someone else stepping in. And so I was elected to that term. And so I became the first woman and the first Black person to serve as area representative. And then at the end of that term, I became the representative. I was elected to that. And I'm serving along with Marianne Albaugh, who is the deputy representative. And I mention this because it just shows the importance of having sponsorship and mentorship. I mean, these are opportunities that have been created, and I really do value them.
Wow, that's amazing. And I even every time we speak, I learn more and more about how you're a trailblazer and you've been in so many roles and positions where you were kind of the first of its kind. And so that's really exciting. And I know you mentioned talking about the different area representatives and the different chapters. And it's funny, when I was at the APA conference earlier this year, I had a medical student come up to me and ask me, like, how can I get more involved with policy or working with the APA in certain ways? And I realized, although I'm a board member of WPS, I actually don't know. And I found the structure of, the APA to be a little bit confusing. So, I'd really love to hear more about your advocacy work. And some of the questions I'm hoping to learn a little bit more about are, what might have been your greatest challenge and what might have been your greatest triumph? Then within the APA system, kind of like how you felt that worked and any advice you would give to somebody hoping to pursue your footsteps.
Okay. I think the best way to answer this question is to take a look at the structure. And so I'm going to do a screen share. And this won't take much time, but the fact that, Dr. Khan, you had that experience, it really reflects the opacity of the APA's organizational structure. And this is just an overview. Some people are familiar with it, but I realized that I did not really understand the structure of the APA, even when I was WPS president. And so you have a board of trustees, you have the assembly, and you have something called a joint reference committee. And under the assembly, you have these area councils. There's 7 of them. And the district branches, there's 74 district branches, they come under that, along with the minority underrepresented caucuses, the resident fellow member groups, the early career psychiatrists, and across is the Assembly Committee of Representatives of subspecialty sections. And so what I want to just focus on here is the assembly. So once you're a member of the assembly, you're able to present action papers to the floor of the assembly. What's important is that anyone can write an action paper. They just need to have an assembly representative as the first author, because only the assembly reps can speak on the floor. And after the action paper is approved by the assembly, it goes to the Joint Reference Committee, which may assign it to a council because more work may be done. And then it can be closed, or it can be referred to the Board of Trustees for approval. I'm going to go to the next slide. Here's something else that people don't realize. The APA is organized in 7 areas. And Area 1 is New England. Area 2, it consists of all of the district branches of New York. Area 3 is Mid-Atlantic, that's us. It includes Delaware, Maryland, New Jersey, Pennsylvania, and WPS. Area 4, you see here, Mid-Upper West. And Area 5, I think of as the original Confederacy. And I'll say something about that in a moment. And I can say that because I'm from South Carolina, okay? And then you have Area 6, which is really California because it's such a big state, and then Area 7. One thing I've always been curious about since I've started looking at this is the Area 5 is really, it consists of mostly the original Confederacy states, with the exception of Puerto Rico, Oklahoma was not a Confederate state, and Kentucky claimed to be neutral. But I wonder why they wouldn't just go up and down, north to south. But I'm still looking for the answer to that. In terms of my advocacy and challenges, this is an action paper that I wrote in 2018 with the help of the people here, Elliot Sorrell, Carl Bell, Ron Bailey. And the gist of the action paper was to ask that there be more education across the professional lifespan about race and racism and its effects. And the second request was to have race included in the DSM, because up to this point, it was not included. In fact, I was watching an interview of Alvin Poussant that was done on Nightline by Ted Koppel in 2001. And Dr. Poussant is holding up DSM-4TR, and he's saying this book does not include racism, it does not include prejudice, it does not include bigotry. Okay, so again, fast forward to after George Floyd, DSM was scheduled to be republished, and it became apparent that some more work needed to be done. And so an ethno-racial equity and inclusion work group was appointed, and these are the people who were included in that. And so our action paper, let me just back up a moment. Our action paper was approved by the Assembly, referred to the Joint Reference Committee, and it was closed, which I wasn't happy because that was before, race was still not included in the DSM. But this illustrates how things are not always linear with the APA. And so while that action paper was closed, people remembered that some of us were interested in this, and people remembered that I was interested in this. And so I was invited to be a part of this committee. And I'll just show you the pictures because the names don't really show, you can't really see the diversity. The committee was co-chaired by Roberto Luis Fernandez and Danielle Hairston. And this is a committee that met and reviewed all of the content in DSM, looking at anything that was related to culture, race, ethnicity, difference, and so that it would be improved. And we have satisfied Dr. Poussant's concern. So in this issue of DSM-5TR, the index, not just the index, but the index includes African American, Black, bias, discrimination, ethnicity, ethno-racial, indigenous, Hispanic, Latinx, prejudice, race, racialization, and racism. And we also push to make it really clear that in cases where misdiagnosis of schizophrenia is made, especially in people from underrepresented groups, we made it very clear that it may be attributable to clinical bias, racism, or discrimination. Before that was not made so clear. And we did this because people come to the DSM, and in some cases, this is the first place that they start to think about these cultural variables. I think that may be it. I'll stop the screen share. So I share that because I feel proud of that, and it's just the beginning. But if you haven't taken a look at your DSM-5TR, do so, because it has become a more relevant book, and the plan is to continue to improve it. I do want to mention another action paper that also illustrates how things are not always so linear. There was an action paper from 2017 that the Assembly passed by Nazanin Silver, who was a resident fellow member from Pennsylvania, part of Area 3. That action paper was passed in 2017, and it went to the board, and it wasn't until, I believe, last year that a council for women was appointed. I think that also was inspired by the Dobbs decision. I mean, clearly we need to have some focus on women and women's mental health.
Yeah, thank you so much for sharing that. And I know I was so excited to hear about your work with the DSM because that is such a far-reaching accomplishment. And when I first came as a psychiatry resident, these are the first things that we see through psychiatry. And actually, I remember having a lecture talking specifically about racial bias and diagnosis of schizophrenia. And I'm actually just connecting now, like, wow, that was the work that you did. And that's really exciting to see it. It's so far reaching. And I also remember at the APA, I went to the Committee on Women's first transition to the Council on Women, and I saw the excitement and I saw kind of the obstacles and challenges that were in the way as well as they discussed it. And I think it's powerful to see that and think, we all want to be advocates or we want to make change in our field or in the nation. And it's not always a linear path, like you mentioned. Sometimes there are setbacks and sometimes things don't happen as soon as you want them to. And it sounds like persevering through that really helps you see those results. And so thank you so much for sharing that.
And I just wanted to add one thing, because women are about 50% of society and about 50% of the APA. But the problem is women make up only a fraction of chairs of departments. So it's not just numbers, it's also representation in terms of leadership.
Absolutely. And I hope if there's anyone out here, trainees or early career physicians that are women, this is just to say to get involved, or anybody who's thinking about it, who feels like they're from a group that they want to represent more, or they want to advocate. I think that this was a great example to kind of see how you can get there with the hard work and the effort and the perseverance.
I want to mention something else before we go forward. And this is about it's a big deal for me to go from Georgetown to GW, because back at that time, really schools were in silos. And so I felt like I was defecting, like going from Georgetown to GW, because we didn't have what we established in 2008, the Career and Leadership and Mentorship Program, inspired by Elliot Sorrell. And so, now it just makes sense. Just the fact that we're doing this and, you're working with a group of residents. This is how it should be. And it does take courage to decide to deviate from what you think your path is.
Absolutely. Absolutely. And I know I have so many more questions to ask you and so many interesting things I'd love to dive in, but it seems like we are getting a little bit close to time and I want to leave time for some Q&A. So I'll give everyone a couple of moments in the chat if they want to post any questions for Dr. Dunlap. As we wait for that, Dr. Dunlap, is there any kind of final thoughts or anything you want to share before we move to the Q&A?
Well, I am going to be presenting on DSM with several members of that ethno-racial group. I'm going to be presenting on Friday afternoon, and we're going to be talking about what we would like to see in DSM 6, because that will probably be the next edition. Mm-hmm. I'm also going to be presenting on the Homes Commission report for WPS on January 8th. And this is part of Dr. Swarty's collaboration with a number of groups. And I'm going to be talking about the importance of the Homes Commission report, which was the Homes Commission was commissioned to look at racism throughout psychoanalysis. And one of the inspirations for that is the lack of diversity in psychoanalysis. And that's an important report, because if our analysts are not trained to think about their own identity and think about themselves as racialized beings, then it's difficult for them to help psychiatrists or mental health clinicians to become comfortable addressing race in clinical care, but also addressing it in supervision and even in research.
Thank you so much for saying that. And I see somebody in the chat saying that they want to say something. I don't think that we're doing unmuting here if you want to type your question in the chat, or maybe I guess we can unmute as well.
Dr. Scarcella says she wants to say something.
I want to say that I know Constance Dunlap for more than 30 years, and I always admire her. And now you talk about discrimination, and it was completely out of my mind when I was seeing you about this experience that you had. Not nice. But another thing I want you to tell is the importance to become psychoanalyst. I'm two psychoanalysts, Jungian coming from Jung, Carl Gustav Jung. You're proper Freudian, right, Constance?
No, I'm not Freudian. I'm probably more eclectic. I trained at the Washington
Okay. So it's,
Analytic Institute.
go ahead. It's so powerful, the information we get about ourselves, because we have to have the psychoanalysis before entering school. That was at my time. And the way we work with the patients is different. Do you feel the same thing, Constance?
Yes, yes, I do. And
Okay.
I think, Dr. Khan, you had asked me about, my own experience and how it influenced me. I mean, for example, I've grown up aware of difference. And I do believe that racism, for example, is a mental illness. And by the way, that was something, there you are, Armenia. That was something that Dr. Husant suggested. He suggested extreme racism is a problem. And Dr. Carl Bell suggested that racism was a variant of narcissistic disturbance. But the APA has stayed away from that. I believe that psychoanalysis and psychoanalytic theory gives us the best tools for understanding difference and understanding power and understanding these dynamics. And in fact, I know that many people have rejected psychoanalysis, but I am convinced it's the best tool that we have. If you have something better, let me know. But that's the reason it's important and it remains relevant. And it's important that we actually embrace it and incorporate it in our clinical care.
I agree with exactly what you say. And the one thing important to understand with the psychoanalysis, you go to the roots of the problem that create the symptoms.
Right.
And that is the best, easy way to do. And another comparison, psychoanalysis is like a surgeon. He has to clean himself first, then he can go inside the body of the patient.
Right. Right.
That's a great analogy. I never thought about it that way, but yeah, you are like a surgeon. You definitely do have to clean yourself first. That's
First.
great. Thank you so much for sharing that. I do have another question for you, Dr. Dunlap.
Sure.
I wonder what are your hopes for kind of the future direction of psychiatry? If you could, have the perfect universe, and I'll make this quick because I see somebody else has a question. What would you say as, your hopes of the future of psychiatry?
Well, starting with the APA, I want us to continue to work on our structural racism. And, think about 1954 when Dr. Charles Prudhomme asked the APA to support the amicus brief, ending segregation, and the APA declined to do that. We have some things that are baked in, and it's important for us to continue to work on them. And just changing the demographics is not enough. Just making sure we have more diverse people is not enough. It does require us taking a look at things dynamically, taking a look at group processes. In fact, that's one of the recommendations that comes from the Holmes Commission report. I mean, it's a radical recommendation that in addition to us having our own analyses and focusing on dyadic care, that we need to have experience in groups, because it's in groups that we make decisions and we set policy. And that's also where a lot of acting out occurs and a lot of resistance occurs. So I also think that we can do a better job dealing with the effect of racism on society. I was reviewing the segment, the Ted Koppel segment with Dr. Poussaint, and what he was advocating for was for clinicians to help patients to understand when, just even if there's a spectrum of bias, aggression, just a spectrum of racism. And the point is that if we can actually help people to talk about things, we can actually help them to dispel some of their myths and can even help them with some of their delusions. Because the notion that, for example, white people are better than everyone else, that is a fixed false belief. I mean, that's, the essence of white supremacy. And a fixed false belief is the definition of a delusion.
Thank you so much for sharing that. Dr. Lawson, go ahead and unmute and ask your question.
Yeah, one of the issues that's puzzled me to some extent, maybe not shouldn't be so puzzling. We did a study about a decade ago, very simple study. Let's go through the psychiatric literature and see how often is racism even discussed. How many studies are there? And I was shocked to discover that this, even during the 70s and during a lot of the discussion of these issues in the newspapers and others, less than 10% of our articles had anything to discuss it or to do anything about it. Recently went through doing another review of the APA journals, and it simply not exist. It's not, and it seems to be very particularly specific to psychiatry. In the social work literature and the psychological literature, there's quite a bit more. Also, and I think part of it also has to do with the funding mechanisms. We did one of the few large-scale studies looking at diagnosis and misdiagnosis, and decided to resubmit and was told that research enough had been done already, that they didn't see the point of funding additional research in that area. So I'm just wondering your thoughts about it. It's great that folks are now talking about it, but why is it that there's still very, very little writing about it versus a whole host of other subjects, especially since we've gotten much more, I think, information in terms of its impact and its implications in terms of our culture.
So, Dr. Lawson, when you mentioned writing, I think about there's two types of writing. I think about the contributions that have been made to the literature by people like Frantz Fanon, Charles Penderhughes. There's a whole slew of people who have been writing about race for years. Mm-hmm. And however, for example, when I was in training for 7 years, from 94 to 2001, there were no articles written by someone Black, and just a few written by women. Because that reflects just the structure, the value. And I understand now there's more literature written by Blacks in training. In fact, a couple of years ago, I was invited to do a class on race and racism. And it's now understood that you don't want to just do a class. You want to address this throughout the curriculum. And there are people like Beverly Stout, Dion Powell, Dorothy Holmes. There are a number of people who have been contributing to the literature, but they were just not included in the curriculum. So that's one aspect. If you're talking about research, I'm not as familiar with the research literature, like the hardcore research literature, but I do agree the psychologists are way beyond us on this. The psychologists and the social workers, they've introduced the concept of race-based traumatic stress. It's not a DSM disorder, but it is a way to capture the way that we are affected by trauma connected to race and racism. And I believe that we can do more.
I think we need also to underline the pride when you, like you, Constance, succeed and become a very important psychiatrist, also at the level of the political psychiatrist, etc. This is a pride that you come out from that. We don't underline the virtue and the strength when you go through a different type of a pathway. Like the immigrant, like many other situations. Mm-hmm. So we have to kind of point a finger in the goodness of certain kind of a problem. Mm-hmm. Which it will be the healing process for the wound.
Right. And I would just add to that, Dr. Scarcella, racism doesn't just affect the object of it. It affects the perpetrator as well. Mm-hmm. The perpetrator, the object, the bystander, the witness. I mean, we all are affected in perhaps different ways, but we also moved away from the notion that this is just affecting the victims or the objects of the aggression.
Any other questions from the audience? Dr. Dunlap, we might have time for one more question and then we'll wrap up. I see you, Dr. Swarrell. Go ahead.
Okay.
Dr. Dunlap, congratulations for sharing with us your rich professional and personal experiences. We live right now in the United States through an unprecedented assault on people's rights and people's hope for the future, and with an emerging sense of new hope that is taking place. I wonder if you would make a comment or reflect on how your patient population is responding to the current path we're traveling now in America. I'll make a brief confession myself. I've been most of my patients have been very concerned about our country. And I decided in April that as a healer, I must develop an optimistic statement, notwithstanding the situation we're in. So in April, I developed this little statement that goes like this. I concur with you all that this is a very difficult and challenging time in our country, but I firmly believe that like the women of Sparta and Athens who saved Greece in ancient times, the women of America will rise to the occasion and save America this year. That was in April.
I like your statement. It's interesting that up until, I would say, maybe the beginning of August, when there was so much despair, I found myself saying, yes, these are very challenging times. That's all I could say. These are very challenging times. I'm also a person who believes in hope. And yes, my patients have been affected. And some people have just been, just downright distraught. And they are affected by, what's happening in the news. And sometimes they have to be encouraged to step away, to manage their exposure. I'm an optimist and I'm hopeful, and I do believe that women make a difference.
All right. I think that's about all the time we have. So thank you so much again, Dr. Dunlap. This was really, really wonderful to learn so much about you and all the great work you've done. And thank you to everyone else, Dr. Sorrell, Dr. Swarty, everyone who helped make this happen.
And Dr. Khan, it's been nice really getting to know you. I certainly know you from our being on the WPS board. It's been nice to get to know you also just as we prepared for this. And I look forward to all the good things that you're going to do.